So, welcome back, everyone, from lunch. So next we have Dr. Guy Schofield, who will talk to us about dilemmas in dying, ethical challenges, and end-of-life care.
Thank you very much. And thank you very much, Arjun, for the invitation to talk today and to think through how definitions of dying and conceptualizations of dying might impact some of the ethical challenges that, that are faced by people looking after people at the end of their lives. So I'm Guy. I'm a newly appointed palliative care consultant at Imperial, based at the Hammersmith Hospital, which is mostly renal cardiology, specialist medicine, a bit of specialist surgery, but a slightly odd view on the world. And then also a senior research associate at the Centre for Ethics and Medicine at the University of Bristol, where I did my PhD, looking at ethical challenges in palliative care. So Arjun asked me to think about what ethical challenges towards the end of life might be and how definitions of dying might impact on those and the way they play out. No conflicts of interest related to the talk. This is a hangover for a medical presentation, isn't it? So what am I going to talk about? So I'm going to set out to start off with my framework that I use and that I developed through the PhD in terms of what ethical challenges at the end of life might look like. I wanted to ground this in practice, and very, very important for me in the research that this was something that was, these are ethical challenges that are present at the coalface rather than challenges picked up by ethicists, perhaps slightly abstract from the clinical world. So I'm going to, for the previous philosophy student in me, is going to make sure I define my terms. So I'm going to set out what I understand about ethical challenges and where I've got this list from, and then look at some of them in this list and where definitions of dying might impact. And then a couple of unasked for extra thoughts around definitions of dying just at the end. So first of all is to understand slightly the difference between palliative care and end-of-life care and generalist and specialist palliative care, so you know which framework is part of the framework that I'm looking at. This is, on the right there is a table from the systematic review that actually Christina mentioned in her talk, looking at definitions of palliative care and symptom control, supportive care, hospice care. And as she pointed out, it's actually quite a variable feast and people don't always know quite what they mean by it. I'm taking, when I talk about palliative care, I look at it in the broadest sense, so that encompasses all of where supportive care is on there, where palliative care is on there, and hospice care. So it's a slightly American model that they've put forward, but I take it as any point palliative care is care delivered at any point from the life-limiting illnesses diagnosis onwards, and not specifically related to dying. So although so care of the dying is obviously a core part of what we do, but it's not the whole of what we do in palliative care. Having said that, the median time between referral and death globally still remains a couple of weeks, I think. So even though this data set that I'm talking about is actually palliative care, which is a broader activity, in reality, there is an awful lot of overlap. The other thing is that my data comes from specialist palliative care practitioners. So generalist palliative care is generally thought of as caring for the dying, a skill level that all clinicians should have. And it's controversial or less controversial from your perspective, but I think dying is everyone's business, and anyone who has direct care of patients will have patients die, and there is a general set of skills that should come with that, and possibly as a middlingly enhanced set of skills if people are dying regularly of your particular disease type. So I would expect respiratory physicians to be able to manage breathlessness, first-line management for breathlessness before calling me. It doesn't always happen, but that would be my ideal world expectation. Specialist palliative care is and so though respiratory physicians doing that, oncologists, that is what's generally termed generalist. It's where people do something else most of the time and do a bit of palliative care. Specialist palliative care is thought of when it is the bulk of what you do. You work in an environment that is aimed to deliver this kind of care with research and training focused on this kind of care. So those are the definitions that I'm not particularly controversial. Everyone's very clear where simple generalist stuff like morphine for pain is and where phenobarbital syringe drivers are on the other end of the scale. Where they meet in the middle is always up for grabs. But this is just saying, this is setting out my understanding. So with that, and the start of the PhD was to look at what are the ethical challenges that happen at the bedside? What does the literature say about that? And the importance of inductive data for me, which is, so there's a lot of literature in ethics on end-of-life care and the challenges that are faced, but they are not, the volume of literature doesn't correlate very well with the frequency the problem appears in clinical care. So there's an enormous volume of literature on assisted dying, but actually requests for assisted dying are relatively rare, or anecdotally for me, requests have been relatively rare. And certainly out of keeping with the amount of time I've been trained on it and have had to spend talking about it. Whereas other things like truth telling and what that means and telling in truth and collusion and value transfers across global settings or cultures, that's not really talked about in my training, but it forms a huge part of my day job. We have a hyper-diverse population that we serve in the Hammersmith. And so this is a really live question every day for me, but I don't see a lot of literature on it. So I wanted to make sure I was talking about stuff that actually happened. So this is the data that I'm coming from, is where practitioners and specialist palliative care practitioners, because they're a more easily identifiable set, describe happening. So we may have missed some, but at least we know the ones that I'm talking about definitely happened. There's a nice study, it's from 20 years old now, from the Netherlands, where Ten Harbour and a colleague sent a bioethics student to do some ethnographic work and followed palliative care teams around, and then compared what the ethical challenges they identified with what was in the literature and found a mismatch. So they found that challenges in the literature weren't observed across 4 clinical settings, but there were also a whole host of things that happened that there was no literature for. So that's why it's a narrow set. What is an ethical challenge? This is more definitions. In my work, so it's not commonly defined with empirical bioethics research. So where even in papers that are looking for the term ethical challenges in real world situations, only about 15% of them define what it is. Which, if you imagine in a clinical paper, not defining the condition you're looking for, and then having a research team multiple researchers going through the same data set looking for it, you just wouldn't get it published. It just wouldn't get past peer review. But in healthcare ethics, it seems to be okay. So I don't think it is okay, but it does appear to be. So I had a definition, and I went for intentionally kept broad to capture the maximum number of examples, ethical issues, moral challenges, moral dilemmas. Some of these have technical meaning, some of them don't. Good, bad, right or wrong. And importantly for me, the challenges could be labeled as such by either the authors, the researchers, or the participants. And that's particularly important in the interview study, which was based in Uganda. And I absolutely didn't want to be importing an ethical challenge concept to a setting where it might not sit particularly well. So a bit of methodology, but just to show the rigor really, 8 for the systematic review, so 8 different databases, not all of them, some of them indexing not in English, no geographical language or time limit. So really trying to capture as much as we possibly could. I have to thank Dr. Ditborn, who sat there for all of the Spanish language work that she did. And it had to be peer-reviewed empirical data, not opinion pieces, review articles, book chapters. So it had to be, it's about certainty. What did we find? 13 studies in the literature in total, and really skewed to the high-income world. Not necessarily the English-speaking world, but certainly the high-income world, all in adult palliative care. So no data on paediatric palliative care, and no data from the vast majority of the places in the world where people die. 6 themes: application of ethical principles that you might imagine people talk about, autonomy, dignity, the things that crop up. And then at the bottom, an interesting one for me, the philosophy of palliative care. Palliative care is a relatively new field in healthcare terms. It's only from the 60s that it's really existed, and it spent a lot of time trying to work out what it is and what it does. And so this is a reflection of the ongoing debate there. And then the ones you might expect. So delivering clinical care, working with patients, and in there is clinical care and decision making, you'll see, and I'll expand that in the next slide so you can see what's in there, because that's what most of you will probably be looking for. And then families, and then the other bits where we have to engage with institutional level challenges, so particularly conflicts between healthcare staff, and this talks a bit about assessments, prognoses, directions of care, value sets within different fields and how they might intersect in a particular patient's care. And then when actually these value sets are broader and they come from societal level stuff more broadly. This is the clinical care one. So this is a sub theme. And it just shows you how much data there is, how granular some of this data can be. But these are some of the things that people worry about towards the and the definition of dying will affect people's assessments of whether these are appropriate or not. So given the huge lack of data from from non-high income settings, the next part of the project was to interview specialist palliative care practitioners in Uganda and see what their experiences of ethical challenges were. And I can talk in the question about why we chose Uganda, but this was actually a research question that came from my Ugandan colleagues. It was one of their research priorities. And we worked with quite a lot of the specialist palliative care practitioners within Uganda, semi-structured interviews, purpose of sampling to try and capture as broad a range as possible, and across an iterative update to the topic guide to try and to change what we were looking for as we went on, and across the spectrum of palliative care. 36 participants for saturation, and a good mix of ages, clinical backgrounds. Men are possibly overrepresented in this sample, and a good range of hospice and hospital and adult and pediatric. So what does this framework look like? So the abstract concepts have gone. This was all contextual stuff. This was all, so talking about autonomy directly had gone, talking about beneficence had gone, and it's all captured within these things. So it's a mapping exercise, and so that's the way my head works. So you've got inside the consultation, which is the kind of clinician, MDT, or whoever's in the room, patient, and whoever's important to them that's in the room, and that interaction between them. Bedside deliberations is a step out, care around the individual patient. Engaging institutions is where the challenge is located, again inside the institution, and where you might go looking for, because part of this is where you might go looking for your solutions, and then broader navigating society. But then also some really complex cross-cutting themes, gender and resources being the main two, and then families here, they're not a separate category in this data, they're just everywhere in the data, so they're a cross-cutting theme. And then a bit about traditional health beliefs, but that was actually much smaller than we expected at the beginning. So do the themes have sub-themes? So these are the sub-themes for the top two, and for engaging institutions and navigating society. And again, these are high-level things that you've seen. This is just to show you where the cross-cutting themes went, but this is the slide to start with. So this is sub-themes. So the thing with interviewing 36 people for an hour and a half each, pretty much, is you get an enormous amount of data points, an enormous number of things. So it takes, high-level themes don't do justice to what's coming through the granularity of it. And even this doesn't quite, but this is, so you look at some of the things in practice that come out just inside the consultation. And I've highlighted the ones I'm going to look at in a minute, because they're the ones where definitions of dying intersect possibly more directly. But one of the points is the complexity here. And I bet if you do this in other fields of care, it will also look like this. And it won't map particularly well to the training programs that are designed to support clinicians with the ethical elements of their work. So one of the themes that came out was the ethical challenge around discussing dying. And obviously a definition of dying is going to be sort of core to that word dying. What are we discussing? What are we trying to talk about? Actually, this was more around the challenges of communication of imminent dying, rather than dying in a broader sense. This was more around that someone's changed and their conditions changed, they've deteriorated, and imparting that information, or doing it some advanced future care planning, or advanced care planning. I'm still not sure which one I prefer. And talking about death in the future and dying in the future. And this hit quite strongly against, so Uganda is obviously a multicultural society, lots of different groups, lots of different cultures intersecting, but there was it went from a great reluctance to talk about it to an absolute taboo, and talking about death. So one of the doctors saying, when you talk about death, then you're calling death, you're calling this thing called death. The other side was about accuracy. We talked about prognostication earlier and about being labeled as a false prophet if overly accurate prognoses fail to happen. And they were another challenge. And I wonder whether the definitions of dying might help or hinder here, in terms of it might set up some definitional boundaries about what can be talked about inside or outside of the taboo area and what is inside it. And it may be that there's something with there. But I suspect the definition of dying is going to be highly contextual. So this is going to play in here too. So this less of a core area, I think, in terms of where definitions might help, but that may be its impact in this challenge. And this is a frequently raised challenge with a lot of participants, adding it in. Truth telling and collusion. So described as one of the biggest challenges palliative care professionals face globally. That was an India-based study. So truth telling and collusion with families or with other healthcare professionals. And it's often the phrase that I've heard more than once is, in our culture, we don't talk about dying. And it is, what do we mean by dying? What do you mean by that? And that was one of the reasons for me to do a cross-cultural PhD, is cross-cultural work. What are the values entailed in this? What do we accept? What do we push gently at? To try and unpick some of this. One of the nice examples to me, obviously people have multiple cultures, I think, was on the ward in Malago, the tertiary referral centre in Kampala. My first visit before the PhD was properly set up, and I was with a very experienced, in his 70s, Ugandan respiratory physician. And he said to me just before we started the ward round and walked onto the ward, so I don't really know why you're here. In our culture, we don't talk about dying. And we stepped out onto the ward, and the very first patient, and if I'd written this as a script, you'd be like, it's not believable. But the very first patient looked at me, he's clearly dying, he's in hours to days left to live. And he looks at me and says in English, am I dying? And it was really interesting that, how to balance that in terms of how do you answer that question? What did he mean by that? What was the significance of it being me? And that opened up the PhD. But that phrase, I think, and definitely may impact there in terms of what it means in different settings and how to answer it. Obviously, I didn't say anything at that point. But some of the things people talk about was things around just the diagnosis itself. Just tell them they have swellings. That was a really common thing I was hearing. Melanoma being a wound from diabetes, or not updating someone. Another one of truth telling is not saying that they don't have a cancer diagnosis, but that it's less serious than it might be. It's not metastatic, it's curable. And it's really interesting. There is a literature that says, from multiple global locations, that says that people do want to know if they have a life-limiting illness. There's a nice study from a neurosurgical unit in Nigeria, and the patients there were saying they not only did they want to know, but they would be actively unhappy if their clinicians or their family withheld the information from them. There's a street survey in Nairobi. We topped every 100th person walking down the street, and they said, would you want to know if you were dying? And 98% said yes. So it's really interesting. Now, there is a caveat there that healthy people are not the best judges of what they want when they're dying. Once they've had their diagnosis, there's a shift there. But it's interesting in terms of what does dying mean? What And how does that feed into truth-telling and collusion? Like, when someone's like, how do you sort of, which bit of dying is the bit you need to communicate? So I think it might help here. I had to put a slide in about autonomy because there always has to be a slide about autonomy at the end of life. But I think definitions of dying might help here, or might impact here too. There's lots of, the classic debate is whether the Western, and I use that in inverted commas, highly individualistic autonomy is appropriate as a model for understanding and promoting decision making in patients across the globe. I put Western in text because there are many Western, or many frameworks that were written in Western contexts that are not highly individualistic. Heather Widdows has a nice paper on this. So I think it's slightly lazy writing when you see it, but the point is about individual autonomy versus relational models. That's often the dichotomy people are getting at. And it's clear in my data that the ability to make autonomous decisions is linked to a person's power, which is strongly influenced by gender, education, financial status, and in Uganda, political status. There's a whole cohort of patients called political patients who have a very different trajectory. And these are people who are well known to a senior politician, and very different trajectory to people who aren't. So I was thinking about how does definitions of dying, how would one feed into this debate around autonomy? And it may not be at the conceptual level in terms of individual autonomy, relational autonomy, but it may be how it's operationalized. It may add or take away things. So a label of dying, I think, does affect someone's status. And so he's going to affect their power in their family dynamic. And it may be that it increases it for a short term, because in some settings, there is an enormous amount of effort put into fulfilling people's dying wishes. So I say I want to go to Disneyland, but I really don't. But say I want to go to Disneyland. If I say that at home now, no one's taking me to Disneyland. If I'm diagnosed with 6 months left to live and I say I want to go to Disneyland, suddenly I'm like, yes, people will try and get me to Disneyland. So it can affect power in both ways. So that might be one way it affects it. I think in relational autonomy, if that's the model you're going to use, or you're tempted to use, and I think it has some strengths, and I think certainly ethics of care and that side, I think, has got a lot to talk to palliative care about. One of my many projects that I don't have time to do. But I wonder whether being labelled as dying affects the nature of the relationships, and whether that starts to be a way of it. So defining someone as dying or not might impact there. It might change. We talked about information giving before. I wonder if it might change the content or the moral imperative about information giving. So someone who's labelled as dying has a different set of information rights than those who aren't, perhaps, or the drive and the importance of giving it to them. So the high income palliative care thing about making people, trying to help people with their acceptance of dying, maybe the urgency changes or the imperative changes at that stage. And then also it may open up simply other options. So someone might have more choices to be autonomous around. And sometimes you'll read that the more choices you have, the more autonomous you can be. Again, not entirely clear to me, but it does open up other treatment options sometimes. So if you're labelled as dying, there's another category of admission to a hospice. So maybe your symptom needs weren't enough to get you there 2 weeks ago. You really want to go there. You really like the pond and the goldfish and all the nice things in the hospice garden. But now people think you're dying, you can have a terminal care admission rather than a symptom control admission. So it might impact the choices available to you. So we can talk a little bit about withdrawing and withholding, because that was one of the things Arthur asked me to talk about. And it's a shame one of to you doctors who was there, who's not there now, this was going to address or talk to one of his points about modes of dying. So withdrawing and withholding for me is one of the things I get asked to talk about or teach on. And it's kind of a classic framework more based in health law, I think, but it's the framework the GMC use, the BMA use in the UK about when it's okay to stop stuff, and the moral differences and the legal differences between acting and omitting. And withdrawing and withholding is an omission to act, and it's therefore not culpable in law. And a lot of this comes from the Bland case and the judgments around that. So I'm going to present this scenario. So an 87-year-old with advanced Lewy body dementia admitted from their nursing home, where they've been for a couple of years with an aspiration pneumonia. No future care planning. No one's thought about whether they would want to come in or whether that was the right thing to do. They've arrived. You're in A&E. You're looking at them. They've been fully dependent for all care and non-verbal for the last 3 months. And these are things that often feed into people's factoring of appropriateness of care. There's no lasting power of attorney. There's no advanced decision to refuse treatment. You've got no idea what this man's wishes might be, but he's clearly actively dying on arrival. As I often say in the referrals to the teams, like, are they dying or are they dying? Which sums up some of the problem. It's like, do I need to come right now, or are they dying in days to weeks and I can come this afternoon? But he's clearly dying. They prescribed IV antibiotics as he came through the door. It's because there was uncertainty as he arrived in resus that unwell, entirely appropriately. But now there's been a little bit of time to bring things together. The family arrive and say that he would not want to have lived like this. And then you can make up some fact to try and defend that judgment. And say he was a professional mountaineer and he loved being outside and he hated being inside. Something to make people feel comfortable with the idea. But he wouldn't want to live like this. And actually, he's so unwell, he's unlikely to even leave A&E. You wouldn't put him in the lift to try and get him to the ward. And the decision's made to stop all attempts at reversing the aspiration pneumonia. Not all aspirations are infective in origin. So antibiotics may or may not have worked anyway, and he dies peacefully. So that was withdrawing of the antibiotics of a potentially reversible intent treatment. And that's relatively non-controversial. This happens reasonably often. And I think most people would agree that is a form of dying that we recognise. The only controversy, I think, is the fact that no one thought to do any advanced care planning before he arrived, because he was also dying in a different sense, perhaps months before. This was not an unpredictable event. This is another form of withdrawing and withholding, and another form of dying, I think. And certainly its effect on the hospice teams when it happens is profound, and it's not treated, even if it might feel the same in law, write the same in law, it certainly doesn't feel the same when you have to do this. So this is a blend of several patients I've looked after across the years. 38-year-old man with advanced motor neuron disease, so no muscle power left, unable to do anything for himself. He is fed through a peg tube, so he's artificially fed, and he's dependent on non-invasive ventilation. He doesn't have the muscle strength to breathe for himself anymore. He's dependent on that. And he has decided that he no longer wants his ventilation to continue. He wants it taken away, and he knows this will lead to his dying relatively quickly after that, because he's so dependent on it. And he has full capacity to make this decision, and he's been through the framework. He's said it to a couple of people across a couple of bits of time, although it's interesting how hard we make people work for this refusal compared to some other refusals in care where I don't want it, you say, okay, fine, that's that. This is a process that must be gone through. The counter argument is obviously this is a process with a very significant ending, whereas having your toenails cut in hospital might not be. But so he asks for this to be removed. And so he's admitted to the hospice. That's where he'd rather have this done. He doesn't want it done at home. And a member of the clinical team, after setting up the various anticipatory medications he might need and a slight infusion, it's removed, and he dies within about 20 minutes, peacefully surrounded by those who are important to him. So in one sense, he is dying. The cause of his illness, the dying is within him, as we heard earlier. But in another sense, he wasn't dying that day necessarily. So it's a change in trajectory. And often it's described as returning someone to their natural trajectory. But I think this does feel this very much, you have members of staff that will not take part in this process. You have to it takes a bit of planning, because you need to have not just that shift with people who are happy to be part of the process, but you need the night shift and the next morning shift in case they don't die straight away, because you can't predict this. So it's really interesting, although it's meant to be a withdrawing and withholding, this doesn't feel like it to a lot of members of staff, and it feels the link between the moving the mask and the dying feels too acute. And so whether this is another form of dying. And then a tertiary type of dying, as I called it. So it's at the Hammersmith, we're about to launch an ECMO service for cardiac patients. Hammersmith, like I said, it's a specialist tertiary cardiology centre, but we're not a transplant centre. The transplants are done at Papworth down the road. So this service is a bridge. So people who suddenly deteriorate, and the question about whether they're for transplant or not is still open. It's not been decided a firm yes or no, and this is a treatment to bridge them until that decision is made, ideally to bridge them to the transplant. But in that process, some of these patients, things will be discovered that mean they're not eligible for the transplant. So you've had someone who would have died, who is now sat up in bed talking to you, and then, but now is dying again in some sense because the treatment they were hoping for is not available. Now this is slightly hypothetical because we actually haven't. I think they've got another half marathon they need to run. So it's charity funded, these equipment. So this is very much fund run dependent. So we're about £20,000 short for the final machine. But they tell me these people are awake and they send the machine off and they die very quickly. And actually, I'm imagining the intensivists in the room can give me more context. But is that a different type of dying again? And it's something in the withdrawing and withholding and the acts and omissions that feels really muddled here. Like obviously with my GMC hat on, I've got the framework, I understand the law, and that's what I practice. But my philosopher head is just saying, hang on, these feel different somehow. And I wonder if the definitions of dying might capture some of that. Because with these kind of withdrawals of treatment, particularly the NIV one, they are really disruptive to the hospice for probably, my experience, for a month. So in the planning, the doing, and then the debriefing. And there has to be something different about that. In terms of the data, so going back to the data, it's not actually a category in itself because actually it's sort of spread across lots of different sub-themes. And that's probably reflects that clinicians don't see withdrawing withholding is it's very rarely taking everything away. It's normally rationalizing things one at a time as you build to something, and it builds into concepts of futility, which I think is goal directed, broader justice, all sorts of things. So yeah, different definitions I might help, I think, at the other level, but it doesn't sit in the data particularly. The challenges around over-treatment, under-treatment, futile treatment, and how you negotiate this and explain this is obviously a very live one. So, another one where it popped up was in assessment of best interests, and particularly where there were multiple sets of best interests in a scenario. And I think that makes sense if you think about it. You all talk about the patient's best interests, but everyone in that room has interests and is going to be affected by whatever happens and whatever decision that's made. And the participants talked about navigating them in terms of definitions of dying. There were two areas. So one was a failure to recognize dying in the other teams. And so perhaps a definition of dying might help there. And then the other was an inappropriate stigma towards dying people. So the first one, this is a clinical officer saying, so when we come with our message of stop this, because the patient is dying, they don't believe us. So that's that a structured definition might help with those kind of disagreements. And then the other was hospice, don't talk about hospice, why should you work on these people who are dying? And so there's and actually the last bit, actually, the plumber that services my gas boiler, when I told him I couldn't leave because I was on call, he had to be a certain time, he said exactly the same thing in West London. So this is not a single view from a single person. But there's something about dying and the value we place on dying, and so the definition of dying might talk to that as well in terms of the normative elements of it. The difference is obviously the heating engineer is not in a position to influence the care, whereas the clinicians they're talking about very much were. And most of us who work in this field will have will be able to remember colleagues who've said something similar or acted in that reflected that value. And then we had someone mentioned ethics of hope earlier. I think it was yourself. So it's interesting. Ethics of hope comes up if you ask clinicians about ethical challenges. Ethics of hope didn't come up in the literature search, but it does come up if you ask patients. So it's really interesting that the clinicians didn't think it was important, but the patients do. Although the patient survey was a single hospice study from the Midlands, a very good one though, and they talked about hope. And I suppose my thought about hope is, people say, oh, you're going to come and take away hope, or you tell someone they're dying and all hope will go. I feel my job around hope is not about taking it away or not. It's about using the motivation that hope generates, but reframing what you're using that energy for. And it's that kind of thing. You're not well enough to go to Kew Gardens, but can we get you in a wheelchair to get into your garden? Like, can we use that energy to do something positive in a different way? And so maybe a label of dying might help explain why we've taken that approach, why we're doing that to in our interactions to maybe a reluctant member of the family. But I don't think it's about taking hope away. I think the skill is around reframing it where you can, although I realize that's not always possible. And so that's definition of dying and how it intersects with the data. And then a few final broader thoughts and then some questions. So one thing come across a few times in my thoughts about definitions in healthcare is that I'm beginning, and in policy and things, is I'm beginning to think that definitions are decision specific or context specific. Like, what do you need this definition for? And that tells you what you might need to put into it. And one of the examples for me, and I've not read a lot of this, so I may be off kilter with this, but one of the examples for me is the question is, when is it acceptable to, essentially boils down to this, when is it acceptable to do something to a person is a moral question. When, why, obtains. So, and I'm working at a transplant center, so when is it acceptable to take someone's organs and put them in someone else? Answer, when they're dead. But you're using a definition of death which has no normative content, if you're being really strict about it, to answer a moral question. And I wonder whether sometimes when we're thinking about definitions of death, some of the scenarios we are doing that again. And so whether the definitions need to be able to take this into account. This is what I mean about what's the goal of it. And when organ donation became possible, it's no coincidence that the definitions of brain death and the different definitions used globally all appeared within a couple of years. It's not me being a conspiracy theorist, it's well documented that they're linked. And then, so definitions of dying starts, you can see how it might work out here. So when do we open up visiting and ask for a terminal care bed in the hospice? When they're dying. When can I get the NHS to pay for all their care needs and skip the really long form? When can we fast track someone when they're dying? When can I stop the statin? Also when someone's dying, but that's a very different time scale, isn't it? And when can I call the Catholic chaplain out of hours? Again, they'll come in for urgent dying. So these labels, they seem to provide answers for other questions. And that's just where there's one of the thoughts that always sits with me. And then also the Catholic chaplain one then made me think, are there theological conceptualizations of dying that a clinical definition also has to cohere with? Because obviously the spiritual world of a patient is often as important or more important than their medical world. Dying is 10% medical and 90% family and social and spiritual and political and all those other things. And so that's another question to add to the discussion. Another bit is about contextualization. So the data in my ethics data, it's clearly highly contextualized. The headlines you saw, you might recognize from your practice, but the granular detail in the huge long transcripts, it has Uganda written all the way through it. And so actually, and so for me, I don't think you can separate applied ethics from the context it's existing in. Now, I realize philosophically that's not universal, that's controversial, but for me, that's the way it fits best. Is dying likely to be the same? A definition of dying likely to need to have that element to them, I wonder. And part of that is the ITU deaths. We were talking about this, setting off the NORAD and dying very quickly. Like, that's a very different kind of dying to me than dying that happens outside of hospitals. So the dying that we see in palliative care when we're looking after people at home is different to the dying in general that I see in hospitals, and particularly different to the dying I see in an acute setting or an ITU. And globally, statistically, obviously, the most common form of dying is at home, away from a healthcare setting and without healthcare intervention. So there's a, I don't know if the data's a little old now, but one of the professors out in Uganda says 50% of people will never see a healthcare worker. So that's the other thing to take into account when we're talking about definitions of dying. We need to make sure we're not talking about a really high income focused definition of the tertiary intensive care unit in a London teaching hospital, but actually does it spread across the globe? And then finally, certainty. You hear this phrase, we all know they're dying. They say it in the MDT. We all know that, particularly when you sit in other teams' MDTs, we all know they're dying, but the team aren't ready to name it as that yet. And what do we mean by that? I think that's a really interesting saying. It came to me first, I was doing a neurology attack with a student, and there was a patient in who had, they were like, we all know they have MS, but for a definition of MS, you need two, this was 20 years ago, maybe it's changed now, but at the time, the definition of MS, you needed two demyelinating lesions separated in time and space. So you needed, and this person had their first one. So by definition, they couldn't have MS because they needed the second one. But they're like, we all know they have MS, but no one said it to them. And it was really interesting, like, how in medicine, how do we know something? When do we know someone has a disease? Is it because we've just made up the disease and made them fit it? Or it's really, this is really interesting to me. And I think dying is one of them. How certain do we have to be? I talk a lot about uncertainty. I say the phrase, I don't know, a lot, because that's the most honest I can be. And it captures some of this, and whether a definition of dying and how it captures that, I think is going to be a challenge.
Thank you very much. Same scenario. Online questions, if they could go in the chat, and then real world questions. Hands, please.
Is this on? Yeah, I have at least 3 questions, but there's no queue yet, so maybe I'll squeeze them in.
You might have to do them one. I'm not very good at remembering the questions. You might have to do them one.
Ah, it's a philosophy conference. Get your pen out, all right?
I'm trying. I've got my book.
No, I will make them all 3 partially, so you can choose whether you want to ignore some of them. So yeah, I thought that was really interesting and great. I have one question that's just pure curiosity, which is the gender came up as one of your cutting themes. And I was just curious, but maybe that's for the break, why gender was such a main thing that came out. A second is, I really liked your jibe. That bit's not a question. This is not a question, I realize. I really liked your jibe, but lack of definition of an ethical challenge. And I started to try, and of course, immediately come up with one on my computer. And it's really hard. And I think it's a really great question to ask and put to the world, the ethical literature, like, what is an ethical question? So, I mean, I can now go on all the bits I already thought about this, but we can also do that in future. So here are the 2 more substantial questions. So maybe it's one question, thinking of a definition of dying, and I'm sorry, I had to run out for some of the earlier workshops. So if I say stuff that's been covered or something, you can just tell me off. So this is kind of taking a step back and putting on my philosophy hat, right? Lots of ways in philosophy you can think of concepts and definitions, right? You can try and get at what ordinary people mean. That comes up. The patient asks you, doctor, am I dying? well, what do they ask, what do they mean? What would does the populace here in Uganda, different language, I presume? Is it the same for all these people? Is it non-contextual? Almost certainly not, because like you already demonstrated, right? Is it dying or are they dying? That means something different from the mouth of a palliative care physician, I'm sure, than from various other people. We can all think in our ordinary language interactions. Lots of contextual. Soon. Um, so one is it, what does the populace means? Another kind of thing is to bring in more heavy conceptual machinery and say, that's important for your communication, but almost certainly the world hasn't thought about this very carefully. Let's come in and do something useful, given the pragmatic aims that we want to hit, which may well be multiple ones. And one thing that struck me here, and I wonder if this is interesting to think about, is we've got all these concepts where we have something social that seems eerily related to something biological, right? Sex, gender. Like you notice from sociology, disease, illness, sick role, right? There's the biology, for lack of a better word. There's the social allied concepts that we build on top of it that build in much more than the biology and also start to float a bit free from biology. Parents, sort of biological substratum, but we have a much more complicated social legal structure. So surely something like dying is about occupying a certain social cultural position, which I would be inclined to think is about reorienting the core parameters by which you figure out your daily ethic of living in a way that reoriented it from placing heavy emphasis on survival, presuming survival, towards that. That is not a big part of the goal here. So we reorient the important ethic towards saying goodbye, making the best of what there is. That leaves a huge amount of flexibility in timescales, in horizons. Also a huge amount of flexibility of like the negotiation of when you want to make. So think of something like gender, right? A negotiation of when you're going to enter that social space. And then, all the issues about prognostication or like biology is relevant input, but it is just by nature a kind of a social category. You get lots of interesting conceptual engineering categories of, is that different in a hospital, in a hospice? Is that helpful at all? Or is that just, no, that's totally not. Go away, Ursula, and that'd be fine thing to answer.
You got all that?
Um, so I'm going to start with the last one and work. Because I can't read my handwriting for the first one. So yeah, I think you're onto something there in terms of the parallels between the social and the biological. I think, yeah, the spaces, the labels allow you to inhabit, and the things you're allowed to do, the reframing, the refocusing of the core ethic of living, that all ties in, I think, with the broader palliative care aim about, I think, about living as best you can whilst dying, rather than simply focusing on the dying bit. So for me, that does map more to how I think of it. I think I have multiple concepts in my head. And I have that broader dying, a bit where I said about dying as 10% medical and all the others. That's, I suppose I mean something slightly different to when I say dying, which is a much more narrow process. And that's information giving to colleagues, like they are dying, we can stop doing this and this and this. I don't know if that answers it. So, but I think, yeah, I think there is cross between them. But I think there are probably other people more qualified to answer that.
I have a finger on this. Just so with a lot of these kind of social concepts which seem to kind of sit or derive from so-called biological things, quite often if you look at them in detail, there is almost no link between the two whatsoever, right? So that automatically makes this very dodgy. But it's a substantial question what exactly we're doing here. Is a definition of dying simply a pragmatic problem? Are we trying to come up with a action guiding concept? In which case, the ethical challenges, could we solve these challenges simply by picking one or of these various concepts, or being clearer about these concepts? Is this just a practical issue? Or is there a genuine metaphysical problem, out in the world, mind independently? Are there some people that are dying, and are there some people that are not dying in the kind of way that we are talking about here, right? So all men are mortal, all men are dying, all women are mortal, all women are dying. But is there out in the world a substantial difference between all mortal humans and people who have a diagnosis of incurable cancer? Is there a substantial difference, or is that just a difference that we want to capture for practical purposes because we want to offer treatment to one group but not the other? I think that's the go ahead.
You're running a bit over.
Yeah.
There's a question online.
So online we have how many colors again? So when trying to communicate uncertainty, for example, around diagnosing dying, do you like the phrase, "We are as certain as we can be," or "the doctors are as certain as they can be"?
I think it depends, which I know is, and it depends on the certainty of the doctors. For me, I think if it's, because there are some conditions where it's very clear, that first scenario I gave you, for example, there is very little room for uncertainty there. So I think if we're in that position, then I'm happy to say we're as certain as we can, because that implies, for me, that implies a level of certainty. Because you could read it as saying we're as certain as we can be because we're totally uncertain. But actually that phrase normally means we are very certain. So I suppose that's how I would, so yeah, if I think I'm trying to communicate a certainty, I might use a phrase along those lines, particularly if it's come from, because obviously we're not the experts in palliative care of the condition the person's dying from normally, particularly the Hammersmith, it's going to be the renal team or the hematology team. So I think, yeah, that phrase for me covers when we are actually all quite certain. But I do hear colleagues, I have an ITU colleague in particular who likes that sentence.
Just two very quick ITU points. One is the link between organ donation and brain death. And I totally agree with you. And if you look at Korea or Japan, brain death only exists in the context of organ donation. So they're inextricably linked. I don't think we get away from that. The other thing I want to say is your MND versus your ECMO patient, the big thing that strikes me about that, the difference there is the patient's wishes. And I've raised that because the first case for me is difficult emotionally, but I don't think is ethically a problem for me. But the second case is a problem we're seeing more and more in ITU, where you've got a patient with capacity who wants to live but has no exit strategy from ITU. And I'm presuming that's what you're talking. And I think that's a very different situation because you've got a huge moral soup of different principles. I don't know if that's what the point you were making, but it.
Yeah, I think that was a more eloquent way of making it. Yeah. So and I think, yeah, we look after, we co-care for people in ITU, and there's definitely a role. I chose ECMO because these are the patients that have to go there while information is gathered, but there is certainly a cohort who all of this work should have been done upstream and should not have come to the unit. And there was never going to be an exit strategy. And actually the moral injury now falls on ITU to.
Give me a definition that stays the same.
I think we will wrap that up there, but thank you very much, guys.